It's my privilege to introduce the next guest of this webinar, Dr. Muzaffar Ahmed. In one line, we can say that he has been the former member of National Disaster Management Authority, NDMA, and former Director General Health Government of Jammu and Kashmir. But let me just add a little bit to his immense experience and knowledge regarding the medical and healthcare arena. For example, he has been a fellow of International Medical Sciences Academy, fellow of National Academy of Medical Sciences India, fellow of Royal College of Physicians Edinburgh, fellow of Royal College of Physicians Glasgow, Royal College of Physicians London, and so on and so forth. So instead of going on and on, I'd like to just, I thought we have already got an impression of his vast experience in the health center, and his how interested and energetic he is. There's a proof of his being associated with this webinar since yesterday, and I can see him smiling right away as well. Dr. Muzaffar Ahmed. Now the floor is on to you, and my co-host Dinesh ji will carry it forward. Dr. Muzaffar Ahmed, please.
Thank you, Rajesh. Dr. Ahmed, a very warm welcome, and we would request you, we would like to hear to your thoughts, and could you please start?
Thank you very much. Let me first thank Mr. P.C. Halder, President of the PPF, and Shri Kem Singh, Vice President, to have given me the opportunity to be in this webinar. Much has been said yesterday by Dr. Kaur and my good friend, Mr. Vinit Chaudhary, with whom I have the chance to work not only as Director of the Medical Education, but during the H1N1 and in many occasions. He has elaborated in detail about how the health system works in our country, and he has made my talk very easy. Let me tell you, I'll not only tell you about my experience as having worked as Director General and Director Health Services for more than 11 years in the state of J&K, but also as member of the Disaster Management Authority. Friends, you know, the increasing occurrence of disasters around the world raises the issue of effectiveness of countries' crisis management system and their preparedness. Disasters can have a major effect on the health of the population and can have direct effect, as it can be death, it can be injury, disability, illness. When we talk to our country, it's not vulnerable only to number of natural disasters which we have seen, whether it's an earthquake, we have been having cyclones, tsunami, landslides, floods, which have been occurring almost every year in many states, with the problem of urban flooding in major metros, which we have seen over the last few years. The healthcare institutions and our health care institutions and hospitals become the victims of these catastrophes. Major hospitals, both in public and private sector, have seen the problem during the urban flooding, whether it was Chennai, Kerala, and the experience in these emergencies has raised the question, first, whether our hospitals are safe, and whether other hospitals and healthcare institutions are resilient to meet the challenges of emergencies and disasters at any point of time. What we need is really a safe healthcare institution, which must be structurally, non-structurally, and functionally sound, to be able to maintain continuous operation during and even after the disasters, whether the disaster is external or it is internal, which can be any which has been mentioned, the utility failure. There have been the incidents of the building collapse of the hospital, fire in the hospitals, even in the All India Institute of Medical Sciences, Bhubaneswar, Bombay, number of states we had, and Emory Hospital, Calcutta, which was the biggest, losing 100 lives in hospital, the patients who were in the ventilators and in ICU. And there was a thinking even at that time when in the NDMA that we need to make our hospitals safe from the emergencies and disasters. We have seen and experienced the problems that when healthcare institutions were lost or remained non-functional, the patients and the people suffered. Our healthcare institutions have to become, safe. And why our healthcare institutions have been, have suffered, I would like to, second Mr. Vinit Chaudhary, that we had chronically our weak healthcare system almost in all states. There was underinvestment, and there has been underinvestment in the health sector. Besides, we had poor facility, location, whether the hospitals in many states, and I would call in my states were constructed, whether it was political reasons or whatever reason was, not taking the consideration of sites, and also the design and construction, and much more than that was the non-availability of the emergency preparedness plan to meet the challenges of any disaster or emergency. Another point which is very important is whether the skills and the competence of the healthcare workers who were not trained to take care during the emergencies, which even we have seen in many situations. So what is required is good planning, preparedness, and capacity development of health manpower for meeting the challenges of public health emergencies, whether it's a natural disaster, it's a biological disaster, what we have been seeing now, or the upcoming CBRN, chemical, biological, radiological, nuclear. As you know, the biological or the CBRN threat is becoming more imminent due to terrorists, and even our hospitals have become the victims in many parts of the globe, whether it was chemical leak or even in the nuclear. And we have the experience of what we call is a Mayapuri in Delhi, where a cobalt irradiator was sold from Delhi University, taken by a scrap dealer, and who cut it into pieces. And it took him 6 days to be diagnosed. Even the person went from the leading hospitals, Max Hospital to All India Institute, 6 days it took him to be diagnosed as a radiation injury. So that raises the question of whether our people about our healthcare, both doctors and other staff, are trained to take such emergencies. Another important question is, do we have health systems, preparedness plans, and contingency plans which have been tested, taken our resources, our manpower into view? And let me give you an example. The super cyclone in Odisha in 1999, where large number of people lost their lives, and immediately after that, Odisha government, the Odisha State Disaster Management Authority, their health department prepared plans for future cyclones. And when cyclone Philin came, or even in Fani, The plans were there, not only for the shelters, evacuation, but also health care. When the IMD gave them the early warning, they prepared at least for 7 days. They had the diesel, they had all the logistics, supplies, hospitals, manpower, diet, everything was there. The movement, and with the result, the intensity of the filing and penny was much more than even the 99. But if you see the number of people which we lost was very low. That was why we had our plans, we had worked on our health sector planning in the state of Usala, and it was because of better coordination and better preparedness that lives could be saved. The same was true of Hudhud even in Andhra Pradesh last year and about a couple of years back. And we have large number of accidents occurring although in small nature, that I would call in major accident hazard units. We have the experience of Bhopal gas tragedy, where we lost large number of people. It was because our health system had no knowledge how to deal with the problem of chemical injuries or even in the major accident hazard units effects. You'll be surprised to know the doctors, when the critical review of the Bhopal was done, it was found that doctors were unable to treat. They had no knowledge how to treat these patients, what are the antidotes. And still, I feel we need to take care of the improvement in the skills and competence in health sector for knowledge and treatment of the chemical, biological, radiological, and nuclear emergencies, which is very important. And I will again repeat, the threat of bioterrorism, chemical terrorism is going to be a challenge in future, and where we have to improve our skills of our health sector employees. And also, I would like to see that we have a good number of institutions like Public Health Foundation of India, which was developed with I would say as a partnership between Ministry of Health and Ministry of Ministry of Health, and as a foundation with the idea to improve the public health preparedness in the country. Although the said organization has a number of institutions in Gandhinagar, which is a deemed university, another is in Hyderabad, and in Shillong, Odisha, and I'm really surprised whether this type of institution or foundation was involved in the present crisis. I'm not aware. In fact, the increasing globalized and what we have been seeing, the urbanizing world, the risk of such outbreaks spreading quickly to all parts of the world is only becoming higher. And our healthcare system, what was mentioned by Mr. Vinit Chaudhary, once we take care in one epidemic or pandemic, then we forget. Our health system gets caught unaware, even what was happened, whether we had adequate stockpiling of personal protection equipment, logistics, SOPs, or even the management protocols. Although in the present crisis, they were developed by the Ministry of Health. And I would recall in the month of November, there was a discussion in Delhi about which Mr. Vinit Chaudhary and we attended, about to review the plans of influenza pandemic. It was just a coincidence that we had that meeting, and what should be done in the such pandemics beyond health, which is very important. Well, we need to, what is, much has been said, and I will definitely agree with Mr. Vinit Chaudhary that the problems in states are much more. Unless and until you have a robust system and political backing for the health system, which we have seen, whether the release of the budget, the health, it's a reality that health was being given the least priority when we were comparing with the sectors of R&B, agriculture, rural development, or other. When I took over as director of the health services in 1999, almost the health sector, because of the problem in J&K, was in shambles. And when I asked that even the district hospitals had to be put in place, and there was no money. I went to my planning commission. He says, you better ask the chief minister. And we, with the help of NABARD and some agencies, were able to raise funds and improved our infrastructure in the district hospitals, primary health centers, and sub-centers. And although the shortage of doctors and paramedicals in the state was not much, but what was lacking was the commitment. People were not willing to go to the far-flung and inaccessible areas because of the low salary. When we asked the government said, yes, you appoint, pay them 8,000 rupees, consolidated salary of 8,000. You can imagine who would go for 8,000 rupees to a remote area, to Ladakh or to Zanskar or areas of Kargil. There were big challenges in the running of the health sector. And again, another question was about the political will for what we privatization. We were not able to rather succeed it, what was even mentioned by Mr. Vinit Chaudhary. If the government is not willing to pay for high-end equipment, MRI or CT, why we should not give it to privatize to run it for the user? For this, our political system didn't allow it. They thought, in fact, during the discussion, they thought, what control will we have? To some extent, the regulator, we would tell them, look, we had the Clinical Establishment Act long back of the Maharaja, which was for maternity homes and nursing homes. Under that act, we will act. But now with the coming up of the Clinical Establishment Act, the action could be taken. But again, the state was not willing to implement that act in total. They said that act is too harsh and it will not be appropriate to have this act in the state. Another question is the what I would call it the marketing techniques of pharmaceuticals. What again I will second Mr. Vinit Chaudhary. Medicines to some extent are available or given, but not adequately, because the budget of the medicines in the health sector is too low. And what happens, the pharmaceutical companies, they lure the doctors in OPD, make them to write the medicines, costly, expensive medicines, which poor men cannot do it. In fact, they not only sponsor the visits of our fraternity to attend the conferences, which I have seen myself, or even with the gifts, for which even in the ethics committee of MCA, where I also happened to, we had changed and clause that the doctors will be punished if it is proved that the pharmaceutical companies, but it is happening and it has happened in the past. And with the result, the poor man, it is the poor man who suffers. and the cost of medicine matters a lot, for which the price control by the appropriate authorities is required. As even in the present scenario, if when we are going to have the antiviral drugs, the pharmaceuticals, even in the, I was reading an article, the drug which is going to cost $7 to $8 is being sold in US for $100 because of the monopoly of the pharmaceuticals, which has to be taken care. And with regard to the testing and of, I would also briefly mention about the in place and transparency in the data, both in the government as well as private sector. The cost of tests is very high, and we know that the majority of our people in our country don't have insurance. In fact, the 4,500 rupees for the COVID test was not being able to be paid by many people because of their low income. And now the new technologies are coming for which the cost may get low. But what is really required is the collaboration among government and private sector in running at the time of the crisis and at the time of these biological disasters. We know initially during the H1N1, when again that was Mr. Vinay Chaudhary was the in charge joint secretary, there were only 3 or 4 labs in the country for testing. And the important thing was, how do we improve the biosafety level of our laboratories for more testing, and also involve some private sector. I think the time has come now that a large number of private sector laboratories, diagnostic centers shall have to play a role. They have to improve, although a policy and plan has to be there, how to help them improve, and because they'll have to invest in this. How do we take care of their investment? And so what is really required is, how do we build a strong and adaptive public healthcare system in our countries? I would not like to emphasize, I would like to rather emphasize that much has been said about we need to increase the health budget, spending in the health sector. And I would like to quote that National Health Accounts data, which was sometime issued in 2016 or 15, the state governments had to spend more than 65%, and 35% was coming from the central government. And again, the state governments were not giving the priority in the health sector. With the result, health departments suffered in majority of the states. So, and even in some of the programs, there was the funding had to be done by the share, state funding on the state share, which many states would not take, and it would delay in taking up the projects or the programs of the Government of India due to lack of funds at the state share. And so what is really required is that funding from the Government of India, which has to be realistic depending on whether population, topography. In fact, when we were when we used to discuss in the Planning Commission about the Ladakh, the norm of the health center, sub-center would not apply in the area like hilly areas of Ladakh. We had to have even sub-center for the 500 population. And second biggest challenge was our urban areas. Urban areas, although after the launch of the National Rural Health Mission, the focus was in the rural areas for improvement of the maternal and child health services. With the passage of time, again, the urban health mission was launched because urban areas had suffered, especially the slums in many states. What we have seen, the lack of the health facilities. We are now going to be having the urban centers is with the urban mission in the new now the program. But in the past, the urban areas, mostly the slums, remain unattended, which is a reality. We are going to have a big challenge of non-communicable diseases in India, and which is that death due to non-communicable diseases are more than 60%. And again, during the emergencies, I think there is some noise.
Yeah, there's some noise. Can you check someone's mobile? Can you mute it, please? Yeah, Dr. Ahmed.
It's going to be a
Please continue. Yeah.
It is going right. So non-communicable disease is going to be a big challenge in our country. And how do we take care of non-communicable diseases during the emergencies as in the present pandemic? What has been mentioned by previous speakers about the people. Imagine about the people who are on weekly dialysis. They don't get that, they are not able to get dialysis, or the people of cancer who require chemotherapy, people of cerebrovascular diseases, even the mental health, people with mental problems. So we have to have a robust system, SOPs. How do we take care of non-communicable diseases during the emergencies? Another challenge which our health system faces is the problem of road traffic accidents. In India, we have every 1 minute we have a road traffic accident. Every 3 to 4 minutes we lose a life. And which NCRB, National Crime Record Bureau, records is 1,56,000 deaths on spot. But the deaths which occur in the pre-hospital, even due to infections, it's around 4 to 5 lakhs per year. And those are very young people, although number of initiatives have been taken, but knowing that India contributes 10% of the global deaths in the road traffic accidents, this is a big challenge where not only the health sector, but Ministry of Transport, civil society, everyone has to do along with the Department of Health. So what really is required is that to make the health system robust and resilient, it's not only the budget and the money, what has been mentioned by Mr. Vineet Chaudhary, but also the skills, proper deployment of the manpower. It should not that we have the manpower, I would say a surgeon posted in a primary health center and a community health center or a sub-district hospital without a surgeon because of whatever the political or other reasons, for which there should be a good transfer policy, and besides need for treatment protocols, which should not be biased for the manufacturers that a representative will come and he will pursue the doctor to write. But once we have good treatment protocols, which we tried in our state, to some extent we were able to succeed curbing the I would say, the malpractice by doctors using the private companies' medicines for the poor people. And again, many of our challenges, how do we improve our blood transfusion services, for which we have, it's a fact that in many states, when we have been talking with our friends, we have worked in silos. We have not been able to have a close networking of private and public hospitals for not only for blood transfusion services, but even other diagnostic services, which is need of the hour. You need to have close networking of and close collaboration and coordination amongst various players in the health sector, which will help to a big way, in a big way, to take care. And also what is really required is the capacity building and improvement in the skills and competence of doctors. My friends, Dr. Anita and Dr. Bhan will agree with me. In fact, in MCI, I also had number of discussions. Unfortunately, the skills and competence our newly doctors is very low. The purpose of internship in our system was that the doctor, after completing the theoretical 4 years or 4.5 years of training, will undergo internship to improve his skills, to know his competence and job. But what happens in actual practice is that for 1 year, the doctor prepares for his post-graduation without taking care or without any interest in knowing and improving his skills. With the result, we may have the doctor who is best theoretically, but practically he has no skills to treat patients. So for that, we need to take care. Even in the present COVID pandemic, you see, all patients don't need ventilation. The oxygenation, what we call is an ECMO, extracorporeal membrane oxygenation, which is simple procedures. They have to be taught. People have to know about the latest techniques, for which we have to have a system of capacity development, which has to be recurrent. Development of public health cadre is very important. Although this was taken up by the Central Council of Health some years back, that they also realized that need for public health in country is very important, for which we need people. I remember a couple of even people from the Ministry of Health were sent for training by, I think during Mr. Chaudhry's time, all the Ravindran and some people were sent to, for doing the MPH, with the purpose that they have the exposure in public health. So we need to have a cadre of public health training. Even we can't have a vertical or a parallel system, but within the existing system, we need to improve their knowledge in epidemiology, in biostatistics, in demography, and even the people from social and behavioral sciences, mental health, psychosocial, all these have to be done. This is really done, and this can be done by training the existing staff, and existing people can be trained for this. And what is also required is that we improve and improve the curriculum of not only our undergraduates, but also postgraduates, both in doctors in medical, nursing, and paramedical sciences, where the concept of emergencies, concept of pandemics is stressed, and the public health is given due importance in their curriculum. We also need to train our frontline workers, which is very important, so that they are able also to communicate in a better way with the community. Although modules for ASHA have been made by the Ministry of Health, but again, more emphasis is required to be given on that. We need to emphasize on the notifiable diseases, and what is important is the Public Health Emergency Act. Even in NDMA, along with the Ministry of Health, we tried to push that Public Health Emergency Act, but unfortunately I don't think that has still gone to Parliament. It is lying in the Ministry of Health. Although the old Epidemic Act has been used and effectively used, but the Public Health Emergency Act is really required. Also in the health sector, although in a private-public partnership, EMS, what we call the emergency medical system, the cadre of emergency medical technicians is lacking in country, like what we have in all West. We have not built the cadre. We need to have a cadre of emergency medical technicians with a regulator. Although government cannot do it, has to be done in the private-public partnership, but there is need for regulation. And in fact, at one time there was a thinking that we need to have an authority at the central level who could regulate emergency medical system in the country, which is really required.
Dr. Ahmed, sorry to interrupt. We are running short of time. तो सवाल भी हैं, please आप अगर wrap up कर सकें.
The large number of people, we lose during the pre-hospital care, and that is because of that need for development of emergency medicine departments. Disaster medicine in various healthcare institutions is need of our. And what has been mentioned about the disease surveillance, although integrated disease IDSP was started with the idea of having a continuous system of surveillance in the country, but its effectiveness and how it works, it has to be seen in totality, and it needs to be strengthened in a big way so that this system is used for our future pandemics or epidemics. Lastly, we also have to ensure that a system and protocols are made to take care of the fatigue and mental health issues among even the responders, whether they are the responders, the doctor from the medical, or even the other like NDRF or other. We have not laid the stress on, we have never thought of that. And we also need to have take help of all our ex-servicemen, retired professionals, and retired, because NDRF is going, they are going to superannuate. We should have an inventory of all that at the district level who can work with the people from health department. Thank you very much.
Dr. Ahmed, thanks a lot. आपने जो अपनी बात रखी और आपका जो वास्ट एक्सपीरियंस है और जो आपने बात शेयर की कि क्या-क्या कमियां हैं and where we need to improve and move ahead. कैसे हम लोग आगे बढ़ सकते हैं. वक्त का तकाजा है. डॉक्टर अहमद, हम जो सवाल है आपसे वो एक साथ पूछेंगे हमारे नेक्स्ट सेशन के बाद. तो मैं ये चाहूंगा, कुमार राजेश इज देयर. कुमार राजेश जी, प्लीज इंट्रोड्यूस last guest and continue with the last session, please.
बहुत बहुत धन्यवाद आपका दिनेश भाई. मिलजुल के हम दोनों ने ये गाड़ी चलाई. But before we move on to the next guest, the final one, Anjali Nair ji, just one little query that's in my mind, which I can, with your permission, Dr. Ahmed, if I can just put it to you, and then we move on to the next guest. Because we still have barely less than 5 minutes for that. Because you've been the DG of Health Services. So in the present context, one of the pointers that I had started the discussion with says that 75% of all COVID positive cases in India at the moment, even as we are talking, is limited to just 30 municipal regions. So we can roughly say that almost 80% of the COVID positive patients are in the urban areas. So do we really have to have that kind of a protocol and modalities for future to have a separate kind of a approach towards the urban area and rural area? Or would you just, what's your take on this, Dr. Ahmed?
I think we'll have to think of having a different approach for urban area slums, because entirely it is different as compared to rural areas because of the population density, because of the availability of the infrastructure in these urban areas. You see, the people from the slums can't go to the big corporate hospitals. If you see the number of government hospitals in Delhi or in Bombay vis-a-vis the population, it's a big challenge. How do they take care? Even I remember we had a big problem in urban areas for establishment of dot centers under the RNTCP, because there were no health institutions in the urban areas as compared to the rural area where we had sub-centers, primary health centers. So we'll have to think for an approach for urban areas whether it's the manpower, whether it's the infrastructure by way of urban sub-centers, improving and increasing the number of sub-centers and the manpower in the urban areas.
Okay. Thank you very much, Dr. Ahmed, for your enlightening views. I'm sure it will be very useful in terms of assimilating our future modalities and protocols at the end of this webinar that we are having for